Sure.
Yep.
Okay. Hello. Yeah.
Hello, my name is Jeswin Sunny, and I'm a fifth-year medical at the University of Central Lancashire. Fatma?
So, yeah, we're just going to go through an A2E assessment. So some universities will have this as a clinical scenario using a mannequin, and others will have it as a structured oral examination, but we've included components that would help you in both approaches. So what does A2E stand for? It stands for airway, breathing, circulation, disability, and exposure. Sorry, the slides are a bit slow here. Yeah, so the main point is that when we're examining each component, so let's say, for example, airway, we go through assessment first, then we recognize if there are any abnormalities there, and then we treat the abnormalities as we see them. So this will just ensure that we treat each abnormalities in order of importance before moving on to the next step. So our first scenario here is in the AMU with a 55-year-old gentleman who has presented with nausea and vomiting. We're asked to perform an initial assessment and with any management steps necessary. So your approach to the station is important because you can walk in confidently, introduce yourself to the person who's handing over. So you can say something like, hello, my name is Fatima Hidayat. I'm one of the doctors on the ward, and you've asked me to see one of your patients. So that person or the examiner will give you the handover. So here they've told us that our patient's name is John Jones, age 55, sex male. I find it easier to ask for any prescription charts or management that has already been given right at the start. But if you want, you can ask it during exposure. It's completely up to you. So I've asked this question, and the examiner has told me now that the patient has received paracetamol because apart from the nausea and vomiting, they are experiencing some abdominal pain. Yep, and then depending on whether or not your patient is conscious or unconscious, you introduce yourself briefly. Hello, hello, John. I'm one of the doctors that's looking after you today. How are you feeling? Take a very brief history, and obviously throughout the whole station, explain what you're doing to the patient. So the patient has responded and they can speak in full sentences. So I've established now that their airway is patent. They don't look pale. I can't see any evidence of increased work of breathing or use of accessory muscles. So I can safely move on to breathing. So as you can see, we've assessed, we've recognized if there are any abnormalities, and we don't need to treat at this point. Next is the breathing. So in breathing, we usually check the respiratory rate. We put on the oximeter to check the oxygen saturations. It's very important to make sure that the trachea is central in position. We check for chest expansion. Is it symmetrical or not symmetrical? The slides are a bit, yeah, this is the picture of how we assess for chest expansion. And then we percuss and auscultate. Depending on our findings, we will either see the need to request a chest x-ray or an arterial blood gas. So in this case, the respiratory rate of our patient is 28 per minute, and the oximeter shows that the oxygen saturations are 90% on air, and chest auscultation reveals that there are bilateral vesicular breath sounds present. So we've discussed this in our previous sessions, the respiratory examination. Bilateral vesicular breath sounds are basically normal breath sounds. So this is a way that the examiner is telling you that the chest was clear. So now that we've assessed breathing, we detected some abnormalities. So the abnormality here is the increased respiratory rate and the low oxygen saturations. I'm just going to give you a few minutes to think about the kind of management that you will do in this step before moving on to circulation. So you can either share your thoughts on the chat box, or just open your mic and feel free to say it. Just have a few seconds. This was not supposed to come now, sorry. So basically, because of the low oxygen saturations, we can give oxygen. So you can say something like, I would like to give 15 liters of oxygen via a non-rebreathed mask. So it's useful to know at this point the difference between a non-rebreathed mask and a Venturi mask. Jasmine, can you please click next for me, because I can't seem to...
Right, yeah.
Yeah, so this is how a non-rebreathed mask looks like. And the difference between this and the Venturi mask is that here, the patient is receiving 100% of the oxygen that we're administering. Now, this is the Venturi mask. And here, I use the Venturi mask with patients where I feel like I need to give a controlled percentage. When do I need to give a controlled percentage of oxygen to my patient? If my patient was at risk of hypercapnic respiratory failure. So this is basically when there is hypoxia, so low oxygen levels, but high carbon dioxide levels. This is not the case with our patient because he doesn't have a history of COPD, doesn't have any history of lung disease. No one told me that in the handover. So I'm okay to give a non-rebreathed mask. Now, the next question that I need to ask myself here is, does my patient need a chest X-ray? Now, throughout this assessment, I don't think that you'll be penalized if you did not order a chest X-ray, just because we still have not identified a respiratory cause for the problem that the patient is having. So if later on throughout your assessment, you felt like you need a chest X-ray, you can order that. But for now, you can just explain your clinical reasoning to your examiner and not order the chest X-ray. So in circulation, we want to see if our patient has any evidence of shock. So we check pulse, blood pressure, capillary refill time, urine output, and temperature. Now, just before moving on to our patient's results, what will set you aside from your colleagues in this station is when you're checking the pulse, the examiner will give you a number, let's say like our case, 120 beats per minute. You can ask a few additional questions like, is the pulse regular or irregular? Is the pulse weak? So this will just show the examiner that you're thinking beyond your level or the level that you're at, basically. So with our patient, he has a pulse of 120 beats per minute, temperature is 37.2, blood pressure is 90 systolic, and capillary refill time is more than 2 seconds. So we've assessed our patient and we've detected the abnormalities. Again, I'll give you a few seconds to think about how you would want to treat these abnormalities that you've detected in circulation. So just while you're thinking, the patient has told you that he's experiencing severe abdominal pain. So what we need to do now about his hypotension and tachycardia is insert two, yes, that's correct, Rachel, I saw your answer. You give 500 milliliters of 0.9 saline stat over 10 to 15 minutes with 2 large bore cannulas. But just before giving that IV bolus, you need to take the bloods that you think you would need for this patient. So those would be some baseline full blood count, urea and electrolytes. And because you did not order an arterial blood gas in your assessment of breathing, it's useful to have a number for your lactate. So you can just order your lactate as well. You can order liver function tests and CRP. So because of the nature of the abdominal pain that our patient is experiencing, which is severe epigastric pain radiating to the back, and he's also having some episodes of vomiting, I would just want to check amylase levels or lipase levels, depending on your hospital protocol. And because he's already had paracetamol and he's still in pain, I'm starting to think about IV morphine. So just to show your examiner that you're using your team, you can ask the nurse saying that, could you please, this is the prescription of the morphine, could you please bring me some morphine to administer to the patient? And don't worry about doses. If you weren't sure about doses, just say that you'll check the hospital protocol or you'll check the BNF. That's completely fine. So a mnemonic to make sure that you'll remember everything in disability is GAP, capillary glucose levels, AVPU, and pupils. Now, I just want you to acknowledge that the gold standard, especially for adults, is the Glasgow Coma Scale. But because in an OSCE situation, you only have 10 minutes, and in some universities, 8 minutes, and you might not be very confident with the Glasgow Coma Scales, just use the AVPU. You won't be penalized for it. And yeah, so for our patients, his pupils were equal and reactive to light, and his blood glucose was slightly high, as you can see here. So his full blood count showed leukocytosis, urea and electrolytes, liver function tests, nil acute, no abnormalities detected there. The CRP was 100, so that's a bit raised. Amylase is 354. Now, can you tell me what is your top differential diagnosis now? You can say it either on the chat box or you can just unmute yourself. So because the amylase is 3 times the upper limit, then we can start thinking of acute pancreatitis. So the next step before moving on to exposure would be to reassess. So I've asked my examiner, how is my patient's breathing? So from 28 per minute, it has moved on to 22 per minute. That's the respiratory rate. The oxygen levels from 90% on air have moved to 96 on oxygen. The chest is still clear. The pulse from 120 has improved because I gave the IV bolus, so it's 105 now. Blood pressure is rising appropriately, but I'm still not very happy with it. So I still want to prescribe a bag of fluids, 1 liter over 2 hours, 0.9 saline. And capillary refill time is 2 seconds. So next, we can move on to exposure. So I have a question here in the chat box. Since it was an epigastric pain, would it be okay to think of stomach-related problems? Of course. And at the end, when you're giving your handover using the S bar, you will give 3 differential diagnoses, and you can say, for example, peptic ulcer disease, or even an uncommon presentation of MI, because it's true that we have a top differential diagnosis, but it's always better to give 3 just to show that you're keeping an open mind and you're trying to rule out these differential diagnoses using investigations and your clinical reasoning. Would you also palpate for any laterally expanding pulsatile mass? Yes, that's a very good idea, especially because the patient has hypotension, but we're just going to do that in exposure now. So what happens in exposure is basically you do a full toe to head examination of everything. So here I'm asking my patient, John, can I please have a look at your legs, please? And I check for any pedal edema, any rashes, and in case sometimes in the scenario they'll tell you that the patient has just had an operation like a few hours ago, so you would check for the surgical wound site to see if there's any if the causing problem is from the surgical wound site, like a hemorrhage or an infection. So with my S-bar handover situation is that I was asked to see if this 55-year-old gentleman who presented with nausea and vomiting and abdominal pain that started 4 hours ago. There was no hematemesis. That's really important to say because it will rule out many differential diagnoses. And the content of the vomit was yellow in color. Past medical history was nil acute. The patient had no allergies. He's a non-smoker and drinks 25 units of alcohol per week. So this will be station information. Don't worry about that. My suggestion is that you put the bulk of your time in your S-bar for A and R, because the examiner has already seen you do the situation and background. They've already basically watched you go through your clinical reasoning. So what they will focus on is the assessment and recommendation. So patient looked pale with weak pulses, blood pressure of 90 systolic, and I've given him an IV bolus of 500 mils over 15 minutes of 0.9 saline. His oxygen saturations were low, so I put him on 15 liters of oxygen via non-rebreathed mask, and his oxygen levels are improved now. I've given him IV morphine for his pain. The blood results showed a high amylase and blood glucose, capillary glucose of 7. On examination, the abdominal examination revealed a tender epigastric region with voluntary guarding of the upper abdomen. Then for recommendation, you can say my top 3 differentials are acute pancreatitis, given his history of alcohol consumption, peptic ulcer disease, and myocardial infarction. I would like to refer him to the surgical team for further management and arrange an ultrasound scan. Now, again, what would set you apart is say that I would keep monitoring the patient until the surgical team comes and takes over the care of the patient. And you can even say, I will keep monitoring him every 13 minutes or hourly or 2 hourly, depending on how comfortable you feel with the patient. So before moving on to the next scenario, guys, are there any questions or anything that you would want to clarify at all? So another useful thing would to say why you're doing the ultrasound scan. So in this case, I feel like I want to do the ultrasound scan just to check if there is any free fluid or pancreatic necrosis, but you can even do an abdominal x-ray. That's fine. As long as you say why you're doing it, it's fine. Even for the top differential diagnosis, it's quite subjective. So as long as you say why you think that this is your top 3 differential diagnosis, that's fine. And the top one will always be what makes sense. The second and third, it's just to tell the examiner that you're keeping an open mind. So it's okay if it was a bit far off from what you think it is. Like, I really don't think that this is a myocardial infarction, but it makes sense. So I'm just putting it there.
That was well done, Fatma. So what we'll do now is just move on to case 2. Okay, so before I begin scenario 2, I just want to tell you that we might have another doctor who will be joining us during the talk. His name is Mr. Bhattacharya, and he is an ED consultant. So if he joins, he would be putting in some important points in the chat. So keep an eye on the chat just to see if he joins and tries to chip in some important points. All right. So now, moving on, I'm just going to my scenario. Right. So this is scenario number 2. So here you have a 40-year-old man who walks into the A&E under the influence of alcohol. He had a fall 20 minutes ago and suffers from a head laceration. The patient is confused and starts to vomit. He is accompanied by a friend. How do you proceed? Anyone want to give it a go on how you would want to proceed with this? Yep. Okay, so what you want to do is just follow through with this. So yeah, what is the first thing you would want to assess in this case? Is it the airway or the head laceration? Any takers? Right, airway, that's correct. So you want to assess the airway because your airway is the first thing that you want to secure, because if a patient comes in, regardless of what the concerns are, if the airway is not secure, that is the one thing that is going to kill them faster than anything else in the body system. So you want to make sure that the airway is secure first, and then do your assessment accordingly. Okay. So now, when you assess the airway, you have to make sure that the patient is able to speak. So now in this scenario, the patient is not verbal because the patient is unconscious after they have vomited. Okay, so here the patient is gurgling on saliva and vomit. So what would you like to do next in this case? Right, so here what you'd like to do is suction the airway because the person is gurgling on saliva and vomit, so that the airway is clear. And once you have suctioned, you can then manage the airway by performing maneuvers and try to secure the airway. So can any one of you tell me any maneuvers that you can do in order to secure the airway? Okay, so Rachel has asked me a question and it's called suction. So where you would want to suction is, for example, if the patient is having a lot of saliva in their mouth, or if they have any liquid in their mouth, it could be vomit, blood, or saliva itself, you would want to take device that has a high negative pressure and then put that into the patient's mouth. So that would suction out all the liquid and then clear out the airway. And so this would allow the patient to not gurgle and take deep breaths in and out through their mouth and through their nose. Does that make sense? Right. Okay. Sorry about that. Okay, so now you can do the following maneuvers in order to secure the airway. So you can do the head tilt chin lift. If that does not work, or if you're worried about C-spine injury, you can then do a maneuver called the jaw thrust. And if that doesn't work either in securing the airway, you then move on to using airway adjuncts. Okay. So now you use the airway adjuncts and secure the airway. So here's an MCQ question for you all. How do you measure if the oropharyngeal airway is of the right size for the patient? I want you all to give it a try and try to answer this question. You can use the mic to answer, or you can put it in the chat box. Any takers on what the answer is here? Right, I've seen that there are 2 people who responded. Yes, C is the right answer in this case. So it is from the center of the incisors to the angle of the jaw. So for those of you who are confused about the incisors, it's the front 2 teeth that is present in front of your mouth. So it's from your center of the incisors to the angle of the jaw, okay, which is right here. So now moving on, you would want to assess the breathing. Here again, you would want to check the patient's respiratory rate, where in this case is 12, and the oxygen saturation is 94%. The chest expansion is equal, and on auscultation, you hear bilateral vesicular breath sounds. Okay, so here you want to make sure that when you are documenting the findings of your breathing, not to mention things like the lungs are clear and they are normal, because that does not actually tell your reader what actually you found or what you're looking for. So the best thing to say is bilateral vesicular breath sounds are present, because this would then tell the consultant or any senior who's reading your notes that the patient has no crepitations, no crackles, or no wheeze present, or no added sounds present on auscultation, right? So once you've assessed the breathing and these are your findings, you then move on to circulation. So in circulation, you want to check the capillary refill, which is less than 2 seconds for this patient. His pulse is 108 beats per minute and is regular. Heart sounds is normal, where there is no added murmurs, and the first heart sound is present along with the second heart sound. You then have blood pressure of 94/58. ECG shows sinus tachycardia, and you do the bloods, which is your FBC, UNE, LFTs, and BBG. Now, when you see these set of results for a patient, what concerns you here? Would anyone like to take a guess, or does anyone know the answer to this question? Is there any factors that is concerning over here? Yes, so it is the low blood pressure and the tachycardia. So I wouldn't go as far to say that the patient is experiencing shock, but yes, shock is one of the differentials you need to keep in mind. Here, the blood pressure is low, so you want to give the patient IV fluids, okay? So here's the fluids that you want to give. You want to give 500 ml of 0.9% NaCl stat over 10 to 15 minutes. Make sure that you tell the examiner how fast you want to give it, when you want to give it, and what fluids you want to give, because that then will tell your examiner that you know what you're giving and how you're giving it. Okay. So just to go back to the comment made before about shock, it's just that you need more information to tell if a patient is in shock. Just by looking at the blood pressure and the heart rate, you can't diagnose if the patient is in shock. You need to examine their peripheries, you need to check their other vital signs, and then come to the diagnosis of shock. You also need to check their urine output to see if it is less. So, which is why I said shock is a differential and not the confirmed diagnosis in this case. Right. Yes, that is correct. So moving on to disability, using the AV-2 scale, this patient is a V on the AV-2 scale. So AV-2 stands for, okay, alert, verbal, pain, and unresponsive. So here the patient is verbal and not alert. So you use the AV-2 scale and then check the pupils. When you check the pupils, you want to use your pen torch and then flashlights and check for direct and consensual reflexes. So direct meaning you would put your hand in the middle, flashlight into one of their eyes and check if the pupils are constricting. And then consensual means you would flashlight into this eye and then check the eye on the other side to see if the pupils are constricting on the other eye. So that's how you check the pupils, and you can then note down pupils equal and reactive to light and accommodating. Avoid writing mnemonics, because that would just create confusion for people who are not aware of what these mnemonics are. So you want to give full sentences when you're documenting. And here the patient has a temperature of 36.6 degrees Celsius and blood glucose is 6.8. Can anyone tell me what the normal levels of glucose are? Any takers on what the normal glucose levels are? Okay, that's fine. The normal blood glucose levels are from 4 to 11. So if it is below, the patient is hypoglycemic, and if it is above 11, then the patient is hyperglycemic. Okay. So next is another MCQ question. So what is not assessed in GCS? Eyes, balance, verbal, or motor movements? Again, you guys can use whatever means to answer the question. I can see that a lot of answers are coming in through the chat. Yes, it is B. So you don't check balance, because when you look at the GCS scoring system, you know that it is E, V, and M, and there is no B in it. So it's not balance. Right, so Mr. B is joining our talk now. Right, another MCQ question for you all. Which of the following is the correct way of scoring GCS of 15? Is it A, B, C, or D? So for a patient like you and I, if we were to score the GCS, what would the GCS be? Yes, that is correct. The answer is C. So here you want to see that it's E4, V5, M6. An easy way to remember is 4, 5, and 6. They're just consecutive numbers. So when you write the GCS, if the patient has a GCS of 15, write it as E4, V5, M6. Okay, and just to talk you through the GCS, it's a complex table, but as you go through the GCS more and more, you become more familiar with it. So that should not be an issue. But for the purpose of your OSCE station, we were given the feedback that try to use AVPU and not GCS, because they don't want you to get bogged down in calculating the GCS while you're in an exam situation and you are panicking and trying to finish the exam within 10 minutes. Okay, so here is the GCS, and this is what the patient has scored. So he has scored a 3 for his voice, a 4 for his verbal, and a 6 for his motor. All right. So you document it as E3, V4, M6, or a GCS of 13 over 15. Right. Does anyone think that this GCS is concerning? If you were to meet a patient who has a GCS of 13 over 15, would that concern you? Yep, I can see there is some answers. Right, okay. So patients with a GCS of 13 is not concerning, and there is a reason why. You want to try to rule out all the causes of reduced GCS before concluding alcohol intoxication, which is what this patient has. Now, I will come to the reason why 13 over 15 is not concerning. But before that, does this patient need a CT head scan? Do you think that his head laceration that he has obtained just 20 minutes prior to his admission warrant him for a CT head scan? You can give me a yes or a no. You don't have to explain and tell me the reasons why. Yes. So in this case, the patient does not require a CT, and I'll tell you why. Here is the criteria for performing CT head scan. And these are the CT head scan guidelines that is set out by the NICE guidance. So you want to make sure if the patient meets any of these criteria, and if the patient does, then you want to refer them to the CT department to do a head CT. Now here, the GCS should be less than 13, but here the patient does not have a GCS of less than 13, but 13 on the mark. GCS less than 15 at 2 hours after injury on assessment in the ED department. Now, had this patient presented 2 hours after the head trauma to the A&E, then he would have received the CT scan. But here, he is only presented 20 minutes after the head trauma. Suspected open or depressed skull fracture, any signs of basal skull fracture, post-traumatic seizure, focal neurological deficit, more than one episode of vomiting. Here, the patient has only vomited once, and had he vomited more than once, he would have received a head CT. Another thing to look at is the next guidance. So for adults with any of the following risk factors who have experienced some loss of consciousness, which this patient has, or amnesia since the injury, perform a CT head scan within 8 hours of injury, provided they have one more of the following. So his age is not above 65, any history of bleeding or clotting disorders, which he doesn't have, dangerous mechanism of injury, again, a no, more than 30 minutes retrograde amnesia of events immediately before the head injury, again, no. So this is why the patient would not be receiving a head CT in this case. So moving on, you want to see the exposure. Here in the exposure, you assess the rest of the body for bruises or bleeding. You then assess the abdomen and then check if there is no signs of bruising or bleeding or any trauma to the abdomen, and check if the abdomen is soft and non-tender. Okay, so some of the reasons why their abdomen would be tender would be because they might have had bleeding, or they might have pancreatitis, like in case 1, or they might have some appendicitis or any other ischemia going on in their bowels, which would cause immense pain in their abdomen and then that would cause them to start guarding. So guarding is when they flex their abdominal muscles and prevent you from pushing down because they are in a lot of pain. The next thing you want to do in exposure is a quick neurological examination, because this patient has been presenting with confusion and also a head trauma. You want to do a quick peripheral nervous system examination and also a cerebellar examination in this case. The patient had vomited, so you want to check and ask the friend that he's come along with whether the vomit was clear, was there any color to it, and here in this case, the vomit was clear and there was no blood in it. Past medical history, you can see you need to ask about that, and then drug histories and allergies, which is very important to ask for, because according to that, we will then be providing the medications, social history and family history. And then you take a collateral history from the friend. If the patient is not in a state to answer any of the questions, you would then want to ask everything to the friend or any relatives that is present with the patient. So how do you manage him now? This patient who you've done an A2E assessment on is now still sitting in front of you, and you need to continue managing him. How would you manage him? Yep. Fatma is completely right in this case. So they might ask you this as a history taking station. They can ask you as an A2E assessment station, or they can ask you what you would do in the following scenarios when you're done, and ask you for your top 3 differentials, followed by your top 3 investigations. Yep, that is another good point by Mr. B. Thank you, Mr. B. So the answer to this question is all of the above. You want to reassess the ABCDE and then see if your vital signs have improved after all the treatment you've provided the patient so far. B, administer IV Pabrinex. C, start an antiemetic because the patient had vomited, and put patient in recovery position because you don't want the patient to choke on their own vomit if they were to vomit again. Okay, so what you want to do is make sure that these are all done for the patient, and then the patient is, sorry, I was just looking at the chat box. So just make sure that the patient has been provided all of this, and make sure that the patient is stable. Yep, and here is your S-bar. So you would provide this S-bar in a very concise and succinct manner, and you want to do it as quickly as possible. So S, situation is that you have a 40-year-old male who presented after a witnessed fall. He had a superficial head laceration and was confused. He also had one episode of vomiting. Background is that he was under the influence of alcohol, no significant past medical history, social history, and he has a chronic alcohol dependence. On assessment, airway is secured with an oropharyngeal airway, maintained oxygen saturation of more than 94%, heart rate of 108, respiratory rate of 12, BP 94/58, GCS 13/15, and your recommendations is IV fluids, IV Pabrinex, and IV cyclozine to be administered, and then admit the patient to the ward for hourly observations. And at this point, you would provide your top 3 differential diagnoses along with your top 3 investigations. Okay. Can anyone give me any differential diagnosis to a patient who has presented to you after alcohol consumption and is now at this state, as we've been discussing so far? Anyone want to give me any differential diagnosis for this patient? I know one of you had suggested one of the differentials by looking at the BP. So shock is one of them. Anyone else wants to go for? Right. So I'll just give the top 3 differentials. So you have shock. You can also have acute pancreatitis because this patient had a binge of alcohol. So if you remember your mnemonic for causes for acute pancreatitis, it's I get smashed. So E in I get smashed is ethanol, and ethanol is alcohol. And then you can also think about what can happen with alcohol consumption and the brain. So patients can have seizures. So you can take a collateral history from the friend and ask, did the patient show any signs of seizures, which is biting of the tongue or a loss of urinary control? Yep. Sorry, there's another comment on the chat box. Yes, it can also be acute alcohol intoxication or withdrawal. So that can also come up as your differential. So these are the things you want to bring up in your differential diagnosis, but remember to provide 3 when you've been asked for 3. Try not to give more than what you've been asked for, because then that just creates a bigger hole for yourself. Although you can do that, and you want to provide your top 3 investigations also, what you'd like to perform for this patient. Okay, once that you've done that, We'll now move on to scenario number 3. And here you have the same patient who has now suffered a fall, and this is how he has presented. Does this patient need a head CT? You can answer it as yes or no, and you can use the chat box or put it in the mic. Yes, that's right. This patient does require a head CT, and I will tell you why. And can you all try to label this? Can you all identify what is happening here and what the diagnosis is just by looking at the picture? Feel free to use the mic because I feel like there's a lot of labels here, so it will be difficult to type it onto the chat box. All right, I'll just give it a go. So A is your raccoon eyes or panda eyes, like the ED doctors would like to call it. B is CSF rhinorrhea. Okay, that's when you have CSF leaking through your nose. C is CSF otorrhea, where you have CSF coming out of your ear. D is battle sign, that's where you have bruising around your mastoid process right behind your ear. And then you have E for hemotympanum, where blood accumulates behind your tympanic membrane, and F is your bump. So in this patient, when you see a patient who presents with these signs, you want to think of basal skull fracture. Okay, so when you think of basal skull fracture, many of the times there are students who would think that it is at the occiput, but basal skull fracture takes place over here at the level of your eyebrows, because that's where your base of the skull is, and it's not at the level of your occiput. Okay, so that's your basal skull fracture signs. And when you assess a bump, you want to make sure if there's a fracture or not. So try to press on the bump. If it is a hard bump, you know that there won't be a fracture, but if it is a soft bump, you can suspect that there is a depressed skull fracture at that point. So that's how you can tell if there is a depressed skull fracture or not. And yes, this person does warrant for a CT because he's had a basal skull fracture. That alone is a factor for him to get a CT. And because he has these signs, there are more reasons why he should get a CT within 8 hours. Okay, so does anyone have any questions at this point about anything at all? Okay, so guarding is just an important point. Guarding is voluntary, whereas rigidity is involuntary, and guarding can be reduced by analgesia. Okay, so this is an important point that Mr. B had mentioned before. So just when you're palpating the abdomen, make sure if there is rigidity or guarding. Guarding is when they flex their abdominal muscles when you press on them. Rigidity is where they don't need to flex. It's just rock hard, and it doesn't go down even if you press on it or you do any other investigations. It would still remain rock hard until you treat the underlying cause. Okay, so your next session will be about the OBGYN station, and the examinations that will be covered is the pregnant abdomen and bimanual vaginal examination, and it will be on the 1st of May 2021 at 3 p.m. And you can register at the BIDA student wing website, and there are feedback forms that is present on the chat box. Please do fill the feedback forms for our learning and so that we can improve our teaching for the next teaching sessions. All right. Does anyone have any questions? Right. So no questions at this point, and I'm just going to stop the recording.